And now I'm going to send you the host request. There we go.
Okay.
Now you should be able to set up your computer, sir. Whoa, okay. There we go. Awesome. Hey, you're getting pretty good at this. Okay. All right, I'm going to mute my microphone and let this go with you, sir.
All right. Okay, everybody. Happy June. I like to do this lecture at least once or twice a year. And so I'm going to apologize. The last time we did this was November. It has to do with EKG recognition. So it is, if you don't have a microphone, be ready to type because we're going to have some quizzes and put everybody on the spot. So the majority of EMS agencies are doing what we call Heart 1. We call it here Heart 1. People can call it anything they so choose. But essentially it's reading EKGs in the field and then determining what the best place to bring a patient is. In all honesty, the best place to bring a patient is somebody who has 24/7, 365 cardiac catheterization. And there are going to be places that are like that. There are going to be places that are an hour ride away, and there are going to be places that are, several hours away for all of you. Protocols will dictate whether or not you transport to the local emergency department, start thrombolytics, and then transport the patient, or bypass the closest hospital and go directly to the cath center, either by flight or driving. So here are objectives. We're going to go over some very basics. We're going to review infarcts and ischemia. We're going to review regional changes, and you're going to have to commit these to memory. So if you have one of your flip books, you can take it out and cheat, that's okay. Or when you see the regional review, get your pen and pencil out and make a quick copy of the, or capture my screen so you can make a quick copy of the regional changes. We're going to briefly discuss the next step after STEMI, and we'll not discuss the more subtle changes. We're going to try and stay out of the weeds. So this is kind of an advanced entry-level EKG. So first thing to do in an emergency is take your own pulse and don't panic. Sorry, audio problem there. Okay, so this may seem a little odd, but this is one of the tricks I do with medical students or paramedic students. And I simply ask a question. Over time, EKGs are like fingerprints. EKGs are like fine art. Eventually, as you look at it, you know what's good and you know what's bad. So what I want you to do is put in your mind what a normal EKG looks like. If you can get down the basics of normal, then you can figure out abnormal. So the first question I'm going to ask most of the time is this a fork or a spoon? A fork would be a normal EKG and a spoon would be an abnormal EKG. And we'll go over some of those changes. So what's going on in an EKG? The first thing we have is a P wave, and that's where the electrical impulse travels from the sinoatrial node to the walls of the atria. causing them to contract. Then at the AV node, the impulse reaches the AV node and delays by about 0.1 seconds. So that's that little pause you see after the P wave before your QRS wave. The bundle branches left and right then receive the signal, and you go from the AV node down the bundle branches, and you begin to get depolarization of the heart. And at that point, that's when you get the QRS complex. And then after that, you get a T wave. And the T wave is your atrial repolarization. So ischemia is lack of oxygen. So once myocardial cells become deprived of oxygen, the electrical pattern for that area of the heart changes. Think of it as this. Let's go back to this. And all of this happens in about a 60th of a second to an 80th of a second, with a normal heart rate between 60 and 80 beats per minute. As the electric impulse goes down here, if there is an interruption of flow called ischemia, you get a change in the QRS complex. If there is dead tissue in here, eventually you wind up with what's called infarct. So injury is you go from normal to ischemia to injury to infarction. Ischemia is the start of injury. It's a decrease in blood flow that outweighs the current demand. So the coronary arteries are supplied, the heart supplies itself, other than keeping the rest of the body supplied with oxygen. It also has to supply its own blood supply. Blood vessels then, as they begin to starve, they go into a period of first ischemia, then injury, then infarct. Ischemia has depressed ST waves. So most of the time when you see a flipped or an ST depression, that's an indication of ischemia. The ST segments are downsloping. The T wave flips from upright to inverted, and then it is usually seen in a regional distribution. So image is everything. So I want you to remember this. This is, a lot of you are not only going to become paramedics, but over time you'll become firemen, or maybe you're already firemen as you become paramedics. And this is the old-fashioned fireman's hat. Fireman's hat is a classic example of infarct, and I'll show you that in a few minutes. So image is everything. So ischemia to infarct is when that injury becomes no longer just ischemic. You start to have death of the tissue. You'll see that the electrical wave now looks like one of those fireman's hats that we just looked at. The ST segments can be flat or elevated, and they can be convex up, and they usually rise above the baseline. So look at this EKG to the right of the arrow, and if you start at a normal state and you go all the way from normal to ischemia to infarction, look at the changes of the QRS complex. So here we have a normal ST, PQRST. First thing we start to do is see flipping or depression of the T wave. And then as we get more depression, we'll start to get a little rise off of the baseline. And then we're starting to show an injury pattern. We're starting to see that fireman's hat. And eventually we get in true infarction where we get what we call a fireman's hat, or some people call these tombstones. So keep in mind that not only is the heart, it's getting returned through the vena cava, the blue blood, and then sending out the red blood to the aorta, it also has to distribute oxygen and blood to itself. So these are the main coronary arteries: the right coronary artery, left anterior descending, circumflex, and the left coronary artery. And these are the important infarct regions. Septal leads are leads 1 and 2, and they are supplied by the left anterior descending, there, left anterior descending. Anterior leads V3 and V4, also left anterior descending. Inferior leads 2, 3, and AVF are supplied by the right coronary artery. That's why the bottom of the heart here is called the inferior portion, and 2, 3, and AVF are the inferior leads. And our lateral leads, V5, V6, 1, and AVL, are supplied by either the left anterior descending or the circumflex here. Posterior is not shown on a 12 lead, but don't forget about it. It's supplied by the right coronary artery. A big R wave with ST segment depression and an upright T wave in V1, V2 can be a posterior MI. And I'll show you a trick called the flip test. We'll come to that in just a few minutes. So this is the one that I want you to screen capture or look for this in your flip books, because this is what you need to memorize so that you understand the changes in an EKG. So every EKG will have 1, 2, 3, AVR, AVL, and AVF, and then V1 through V6. Keep in mind that inferior leads are 2, 3, and AVF. Septal leads, we just talked about, 1 and 2. Anterior, 3 and 4. And lateral, 5 and 6. Why is it important? Is as you look at an EKG and you start to see a pattern of injury, where you see the pattern of injury determines where the MI is. Now, there are some reciprocal regions, and only the lateral and inferior regions have reciprocal regions. So if you have ST elevation in your inferior leads, you're most likely going to have ST depression in your lateral leads. Non-reciprocal changes, anterior infarcts may not be accompanied by reciprocal changes, and septal infarcts may not be accompanied by reciprocal changes. They usually stand alone. All right, what is not a STEMI? STEMI stands for ST elevation myocardial infarction. And there are certain things that I'll introduce you to, but you don't have to memorize just yet. For example, pericarditis. Pericarditis is diffuse ST elevation. Essentially, you have ST elevation in almost every lead. Think about it. Heart attacks are usually blockage of one vessel, sometimes two. But in pericarditis, you've got ST elevation in all of your regions. What are the chances of all four major vessels having blockage at the same time? Critical blockage, it's pretty low. So pericarditis kind of looks like an infarct, but it's diffuse. Left bundle branch block is also different. ST segment elevation V1, V2, V3, up to 3 millimeters in left ventricular hypertrophy and strain, and asymmetrical T waves are possible. STEMI, or ST elevation MI, are pathologic with these changes. Number one, an ST segment of 1 millimeter or more of a flat segment. So here's your baseline, and then elevation of 1 millimeter there. ST segment of 1 or more with a convex XT segment, like this. ST segment of 1 millimeter or more with convex ST segment, or a tombstone. So this is your tombstone, what I also have referred to as a fireman's hat. Sometimes you get a symmetrical T wave with an elevated ST segment. Or you might have a biphasic T wave that's more negative and positive at the beginning. And that sometimes you have reciprocal changes. And we talked about these regions of distribution. And here's the most important thing. History is consistent with an acute MI. So you have a diabetic who's a smoker, who has a history of hypertension. He's sweating, he's diaphoretic, he's having chest pain after shoveling snow, but maybe has a normal EKG. Maybe that EKG is normal for now, but it'll change in time. So history is really important, and if you suspect an MI, go ahead and treat for an MI. In 2015, the American Heart Association made some changes in refinement of what they called a STEMI, or an acute MI. Women only need a 1.5 millimeter ST elevation in V2 and V3, or men 2 millimeter in V2 or V3, or 1 millimeter ST elevation in 2 or more contiguous leads, and local ED calls a STEMI based on a transmitted 12-lead EKG if available. So in some places, you're going to have to transmit the EKG to be overread by the emergency physician. In a lot of places, our region included, paramedics make the call and go ahead and activate a Heart 1. That means at 3 o'clock in the morning, if they activate a Heart 1, that brings the cath team in and wakes up the cardiologist. Not all myocardial infarctions are STEMIs. STEMIs are acute MIs that are treated differently by transporting directly to a STEMI receiving hospital. And that's a decision based on the 12-lead EKG. That's the first thing I said when I was talking to you. And all chest pain patients are an emergency and treated as such. Chest pain has the potential to be a non-STEMI, and a non-STEMI can be injury to the heart without acute ST elevation. And those patients they're not downgraded, but they don't go directly to the cath lab because they might be having intermittent ischemia, and they might be able to be handled medically. So what is acute coronary syndrome? It's a definition of a sudden ischemic disorder of the heart. It includes unstable angina and acute MI, and it represents a continuum of a similar disease process. What do I mean by a continuum? I'll show you in just a minute. Hopefully you can hear this.
Coronary syndrome, or ACS, is the leading cause of death globally. The spectrum of ACS ranging from unstable angina to non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Ultimately, ACS is the result of an obstruction of the coronary arteries induced by an atherosclerotic plaque. ACS events are triggered by the plaque rupturing that exposes subendothelial matrix proteins and other molecules. Platelets are recruited to the site, adhere to the injury, and, together with red blood cells and fibrin, begin to form an arterial platelet-rich clot. It narrows and eventually obstructs the coronary artery. The extent and the location of the blockage and the resulting myocardial damage determine the extent and the severity of the myocardial infarction. Life-threatening arterial clots are formed through two pathways: activation of platelets and generation of thrombin by coagulation factors. Targeting both pathways has been shown to be a viable therapeutic approach.
Okay, so let's talk about the initiating of events. Inside the vessel, there has to be a plaque rupture. There has to be thrombus formation. Then that's accompanied by vasoconstriction. So here is what we call a plaque. A stable plaque has plenty of room between the lumen of the vessel. This is where those red blood cells go through, and the lipid core. So when your doctor talks about putting you on low cholesterol medication, what they're trying to do is treat this lipid and make sure that you don't get a buildup of cholesterol in your vessels. A vulnerable plaque is one where right below the surface of the lumen is the lipid core, and the fibrous cap is very thin. So look at the fibrous cap on the left. It's got plenty of room, and on the right, it's very, very thin.
Woohoo! Look at that blubber fly!
So when the cap comes off and the lumen of the vessel is exposed to this lipid core, that starts the beginning of an acute coronary syndrome. So that you saw the red blood cells were flowing through, and the next thing you know, platelets begin to adhere, and it begins to cascade. So platelets begin to adhere, and it's a cascade that can't be stopped. That's why we give aspirin right away to people who are having chest pain, because aspirin will inhibit these platelets for the life of the red blood cells, which is about 120 days. But it's hard to stop this. It's kind of like, I make this analogy of when you're in high school and you find out that somebody's going to have a few people over and have some beer, and the next thing you know, they tell two friends and more friends and more friends, and before you know it, the whole school is there. And that's what happens. So these platelets invite other platelets, and before you know it, the vessel and the lumen, nothing can get by, oxygen can't get by, and you start to go from ischemia to injury to infarct. And then this fibrin starts to lay down a network and make a clot, and that's what has to be broken, either by an interventional cardiologist going in there or TPA going in there, clot busting agents. So you can see over time, that last little bit of lumen you get some vasoconstriction going on, and what was a larger vessel now becomes a smaller vessel, and that's a response to the platelets, and that causes increased pain. Now, this is also why we give nitroglycerin. Nitroglycerin is a vasodilator. So we're on the right here, and we're getting less and less oxygen through here. We give nitroglycerin, and that dilates the vessel, and now more oxygen can go through. So all of these factors can happen: thrombus formation, plaque rupture, oxygen demand, vasoconstriction, and whether or not we get tissue death depends on whether or not we've got decent alternative circulation. So, give yourself a number at this point in time. Am I seeing a question? Why is TPA typically used for CVA and TNK used for AMI?
I got to tell him.
Well, that's kind of beyond the scope of today's lecture, but tissue plasminogen activator is used for both. One is, and it's just a different brand and a different concentration. It's still the same thing. Okay, so I'm going to ask everybody to take a number.
Hey, Dr. Eschelbach.
Yes.
Just letting you know that you've got 2, maybe 3 that are not past cardiology, or actually 2 of them I think are EMT students tonight. So bear with them if they struggle along, because some of them are going to be clueless. I guess we have some extras that joined us tonight.
Okay, that's fine. That's fine. So let's go. We'll start with Gary. Make Gary number 1, Brian number 2, Carrie number 3. Let's see who else. Jason number 4, Tara number 5. Okay? Is that correct? All right, number 1. Okay. Unmute your microphone and tell me what you see.
I see a sinus rhythm, normal axis.
Okay, that's good. Let's go back to a basic. Is this a fork or a spoon? Fork is normal, looks mostly normal. Spoon looks mostly abnormal. So is it a fork or a spoon?
I'd say it's a fork.
It's a fork, good. Now let's look at our regions. 2, 3, AVF, inferior. There's a P before every Q. There's a QRS that's upright. And then AVF, your T wave is upright. So 2, 3, and AVF look pretty normal, don't they?
Yes, sir.
Good. All right, now let's go to our anterior region, or septal region, V1, V2, P, QRS, P, QRS, and there's a T wave is upside down in V1, but that's normal. And then V2 is on the line, so V1 and V2 look pretty good, don't they?
Yes, sir.
All right, and now let's go to V3, V4. Do you see any abnormalities there?
You have a T wave that's a little bit shifted to the right, so it's not
Right
quite
here?
asymmetrical.
Right here, a little slurring, yeah.
Yes, sir.
I think that's okay. And
But-
V5 and V6 are lateral here, and they look pretty good too.
Yeah.
So all in all, you said it's a fork. Is there a STEMI or no STEMI?
No STEMI.
No STEMI. You want to call it normal?
Yes, sir.
All right, good. That's a normal EKG. All right, who's up? Who's number 2?
Okay, that would be me.
All right, Brian. Here we go. So first question, is it a fork or a spoon?
Sorry, I'm trying to get a. Okay.
We'll go back one. We said that was a fork. We said that's a normal EKG. Do you see a difference between this one and that one?
The S wave looks a little different.
What region looks different?
Down in lead 2, there's that big loopy S to T.
Here?
Yes, sir.
Okay. So we'll go through 2, 3, and AVF. They're a little bit different, but not too bad. We'll go back up one and go down one. They don't look too bad. I'm going to call your attention to V1, V2,
Yes.
3. Do they look the same?
No, the ST part is way elevated.
All right, so ST elevation. And ST elevation is in the septal region
Yes.
and in the anterior region. So if we had to say that this was an MI, what would we call this? If we're calling in, this is 471. I have a 29-year-old male who's doing cocaine, who's complaining of chest pain, and EKG shows ST elevation of V1, V2, V3, V4, consistent with
Anterior septal.
anterior septal MI. Very good. So, good job, Brian. So,
Thank you.
you've got the ST elevation MI. We talked a little bit about some slurring here, but we couldn't quite call it anything other than a non-specific ST T-wave change. There is some depression in 2, 3, and AVF, and you picked that up. There's also some mild depression here in V6. Okay, who's next?
I am.
All right, Carrie. There you go. So, first, is it a fork or a spoon?
A spoon.
All right, good. It's a spoon. Doesn't look right.
Nope.
Where does it not look right? So let's go.
Everywhere.
Okay. Kind of everywhere.
Kind of everywhere.
All right. Well, let's look at 2. Let's look at 3, and let's look at AVF. 2 doesn't, actually 2 is pretty normal appearing lead. 3 looks upside down, and F looks upside down. So there's ischemia in the inferior portion. How's V1 look?
Relatively normal. It's not-
Yeah, relatively normal. The T wave is up, and it's usually down, so that's something going on. Now, how about V2?
ST segment is definitely elevated.
Yeah. These are those tombstones we talked about. Tombstone, 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 tombstone. So we've got changes in our anterior, septal, and lateral leads. And if we go all the way out to V6, here's the baseline for V6. It's at least 3 boxes elevated. So we've got, we don't usually call an anterior septal lateral MI, but we usually call it a anterior lateral MI. So is that what you would agree with?
There's quite a bit. I mean, that's quite a few leads. It's normally not that many, correct? Wouldn't that be more indicative of infection, like pericarditis or something along those lines?
Well, the thing about pericarditis is these are injury patterns, and they're not all upright. 3 and AVF are going down, so they're showing ischemic changes. Ischemic changes, and 2 looks normal. So you're right. There's a whole lot of abnormal here, but it's an anterolateral MI. Okay, good job. Who's next?
I am.
Jason?
Yes, sir.
All right. So there's a question here. Is it a fork or a spoon?
Okay. It looks like a fork.
So it looks mostly normal.
Correct.
Right?
Yes, sir.
Okay. However, look right here. Do you see that off the baseline right there?
Right.
In 1. So where is 1? 1 is a lateral lead. So let's look at 2, 3, and AVF. There's a little bit of depression right here in 3, right?
Right.
So, and a little bit of downsloping right there. So very, very subtle. 2 looks pretty normal, but 3 and AVF show very, very subtle. Then we go over to V1 and V2. They don't look too bad. V3 doesn't look too bad. And what's going on here with our T waves?
Got the spoon.
Yeah, they're upside down.
All right.
So the machine says, suspect MI. Yet it looks pretty much, I would agree, when I first look at this EKG, it looks like a fork. But then when I start to take it apart, I said, oh, there's a little something. There's a little something that's abnormal. It's very, very subtle. And then these T waves are flipped. So this is a really hard one. And it's a very, very early MI. And pretty soon, as those platelets keep congregating, you're going to start to see these go upside down, and then you'll see the ST elevation over here. So that was a hard one, and that's in there to trick you, and that's okay, but you did well.
Thank you.
All right, who's next? Is Tara next?
I see Tara's unmuted. Tara, are you trying to talk and nobody can hear you? Yes. Okay, go ahead and type, Tara. You can type the answers. Dr. Eschelbach can see them.
Okay. Here's our EKG. I'm going to have to look at the chat box here. All right. Okay, so fork or spoon, F or S? All right. Fork is normal. You're saying that's normal? All right. Yeah. Spoon. Let's say why. Okay. Had to move to chat. Got it. So, is 1 normal? Depression. Good. How about 2, 3, and AVF? Elevation 2, 3, and AVF. Good. So you've got ST elevation in 2, 3, and AVF with lateral 1 here, here, and these look okay, V5 and V6, but you've got reciprocal changes, 1 in AVL are reciprocal, that's good. So is this a STEMI? Yes, sir, that's right. 2, 3 in AVF, it's an acute inferior MI. Good job. Okay. Who's next? we're back to the top, right? Last one, Tara. Okay. Gary, is that you? Is that right? All right, Gary, do you have a microphone or no? Okay, got it.
Yep, I have a microphone.
Okay, there you go. Okay. Boy, I seem to be stuck here. Hold on. Oop. Okay, there you go. So, Gary, fork or a spoon?
That is a spoon.
Okay. What do you see?
We have ST elevation in 2, 3, AVF, V4, V5, V6, with depression in AVR, maybe a little in AVL, V1, and V2.
Okay. So V1, V2, we've got inferior leads, we've got ST elevation. So we've got inferior MI, and we've got lateral MI. And so we want to call this, what do we want to call it?
An inferior lateral MI.
There we go. Great. ST elevation 2-3 AVF, depression V1 and V2, you got those right away, and ST elevation V4, V5, V6. Good job.
Thank you.
All right, who's next?
Me, sir.
All right. Here we go. Here's what I'll tell you.
This is a spoon.
Yeah, it's a spoon. Good. And it's a little bit of a trick. It's a little bit of a trick. So if I tell you it's a little bit of a trick, go through it systematically and tell me what you see. Start with your lead one.
I have a really small P wave. ST wave, S wave does a dip.
Right. What do we call that dip?
Ischemia.
Yeah, depression in one. And then here's L. All right. And then let's go to our other lateral leads, V5 and V6. Do those look normal?
No, those are way below.
Yeah, those are all okay. So we've got lateral ischemia. What do we see in inferior leads? 2, 3, and AVF.
Depression in 2 and AVF.
All right.
And then 3 has a little bit of depression, not as much as the other two.
Okay, so we've got half the heart covered. V1, V2, V3, V4, they all look depressed, don't they?
Yes, sir.
So this is pan widespread ST depression. This person is having ischemia all over. So they might have a low blood pressure. See, their heart rate is 122. So their blood pressure might be low, or they might be going into shock, and they could be going into myocardial shock or something like that. They could have had a major MI in more than one vessel, and that's widespread ST depression. So that was a good job.
Cool, thank you.
All right. Next one.
That's me.
All right. There you go.
It's a spoon.
Okay. Tell me where it's a spoon.
Leads 2, 3, AVF have elevation.
Good job.
V3, there's maybe a little bit of elevation. Maybe some,
Yeah, maybe 1 millimeter, maybe so.
maybe just a little bit.
The other leads look
Okay.
okay.
Not really seeing any
Yeah.
typical changes.
So 2, 3 and AVF, what is that?
Inferior.
All right, so ST elevation, inferior MI. Good job.
Thank you.
All right, who's next?
Me?
All right, Jason. There you go.
That looks like a fork. Actually, let me rephrase that. Looking at it closer, it looks like a spoon with V1.
It is a spoon.
Yeah,
Yep.
V1, V2, and V. Yeah, V1 and V2.
So let's
go
go
ahead,
back
I'm
to our thinking. Are these QRS complex narrow or wide?
There, where your mouse is.
Yeah, here, here, here. Actually, all over.
They're all over. They're wide.
Yeah. How about this little notch right here?
That's narrow right there.
Yeah. And do you see that little hitch in the giddy up? I'll call it right there.
Right.
All right. And now we've got some wide here and wide here. It's kind of a tricky question, but it is a spoon, and it's very, very difficult because this is left bundle branch block. So your bundle branches are not equal, and one slightly ahead of the other. And because one is depolarizing slightly ahead of the other, it widens the QRS complex. And you see these little notches in the QRS complex, and you see a widened QRS complex. You almost might be tempted to say, hey, that looks like a fireman's hat, but it's not, because you've got wide QRS complexes. So that's a tough one. That's a left bundle branch block. So
You gotta look at it close right there.
yeah. So if you look there and there, it's a tough one.
Okay.
All right, next up. Diagnosing an acute MI in patients with a left bundle branch block is so fraught with peril that the safest course is to never make an EKG diagnosis of AMI in patients with acute left bundle branch block. All right, who's next? All right, good. Very good. Tara. Says me. Okay. Fork or spoon? Spoon. Good. All right. What do we see? Let's look at our lateral one and AVR and our lateral leads. What do they look like? Wide QRS, that's correct. And do we have a wide QRS in 2, 3 in AVF as well? Yes, good. Do we have a wide QRS in V1, V2, V3, and V4? In all leads, okay. So wide QRS, what do you want to guess? Yes, it is. It's a block. All right, on the Lagrange block. Widen QRS, QRS down, V1, V2, V3. Sorry. All right, good job. Who's next?
I believe we're back to me.
Okay. All right. Here's your EKG. Fork or a spoon?
It's a spoon.
Okay. It's a spoon. This person's having chest pain. They're 74 years old, and they're out taking a walk, and they just got more and more exertional chest pain and shortness of breath, and decided to take 3 or 4 extra blood pressure medicines this morning.
Excellent.
What's going on here?
Looks like they are in a second degree type 2 block with, I don't know, maybe 3-to-1 conduction.
Second degree?
Yes, sir. The QRS complexes don't appear to quite march out even.
Right. But what's the rate? If we were to look at the rate, let's see. Here's our marker here and here. So 1, 2, rate's about 30.
Yes, sir. For your ventricular rate, and then your
Yeah. Second degree block usually doesn't go down that low. It's a block, you're correct. Let's go over blocks. First degree is just a wide box, right?
yes, sir.
And then second degree block, there's Mobitz 1 and Mobitz 2, or Winky block, where the QRS complex gets continually longer. Or complete heart block or third degree block, where there's no AV dissociation, and you just fire the guns because nothing else. So you've got a P wave here, P wave here, and nothing following. 3 P waves. And then you've got this ventricular firing here, right? So here's a P wave, P wave, P wave, and then a P wave. They all seem to march out the same, but the ventricle's not firing. So the ventricle just says, I'm not waiting for you, I'm firing or I'm going to die. So what kind of block is that where the ventricle takes over with this complete?
That'd be a third degree block.
Third degree AV block or complete AV disassociation. All right? All right, it's probably a ventricular escape rhythm because that ventricle is waiting. The atria is going fire, 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 fire. And nothing happens, so the ventricle just says, screw you, I'm firing. Boom.
Yeah, the first 3, it looked like the PR interval was consistent, and then I hadn't gotten to that last one yet where there's obviously a big disconnect.
Right. All right, that was a tough one. Good job. Next.
Me, I'm ready.
All right, what do you see, Brian?
It's a normal, regular P waves, but we got some elevation again in the anterior and septal, as well as the just V1, V2, V3, and V4.
Okay. How does 2-3 and AVF look?
A little depression.
A little bit. How about our lateral leads? 1, AVL, V5 and V6. A little bit of depression maybe right there,
Yes.
but not too bad. So we've got anterior and septal elevation. What do you want to call this?
Anterior septal wall, MI.
There you go. Good job. See, it's easy. If you take an EKG apart, one little bit at a time, you know your regions, and then you go from there. All right. Good job. Next one.
My turn.
All right, Carrie.
It's a spoon.
All right. It's a spoon. It looks funky. Where does it look funky?
Let's start with 1. There's depression in 1.
Okay.
Some slight elevation in 2, 3, AVF. V1.
Is there elevation in 2, 3, and AVF?
No, there's depression.
Okay. Okay.
Yeah,
Right.
I was
Okay.
talking about leads 1, 2.
Okay.
1, 2, and 3. Started at the.
All right.
Yeah. V1 looks okay, maybe.
Yep.
Looks pretty normal. V2, V3, V4, V5, and V6 all have depression.
Yeah, they all look depression. And look, here's a hint. Somebody threw this in there. What's that? That's an extra lead we haven't seen before.
I haven't seen that one.
Okay, V4 right-sided lead. And here's what this is. And this is so if this guy is complaining of chest pain, 9 out of 10 chest pain, and he's got this EKG, and he smokes, and he's got a history of diabetes, are you going to wake up the cath team? I would.
Yeah.
I would. All right. It's really hard. There's ST elevation in 2, 3, and AVF. You figured that out. And then there's reciprocal changes in 1 and V5 and V6. You figured that out. And there's posterior ST depression in V2 and V3. So that's posterior leads. You see, if you look at it upside down and backwards, it looks like an MI. So take that EKG in your head and turn it upside down. See if I can do that for you. No, I didn't do it for you. But what this does is when they go down deep like that in V2, V3, V4, all right, that's why somebody did a right-sided lead, and that's why you have this extra right-sided lead. So that's a inferior, posterior, right ventricular myocardial infarction. That's a mouthful. That's a lot of ischemia. That's a lot of injury. Okay. We got 3 more left. Who's next?
That's me.
All right, Jason.
You got a lot of stuff going.
Fork or a spoon?
It's gonna be a spoon. We got a lot of stuff going on here.
Yeah. Doesn't look right, does it?
Right.
Okay. Looks a little wide.
Right.
Okay. Now, think back to the left bundle branch block. We saw these things. We saw wide QRSs. And we saw wide QRSs all over, right?
Right.
But something else in this EKG that was not in the other one. Keep this in your mind. I'm going to go back. There's that bundle branch block. All right, look at that. It looks pretty similar, doesn't it?
Right, especially V1, V2, and V3.
Yeah, it looks pretty similar, but there's something else in this one that your eyes got to pick up. What is this?
That's what I was getting ready to point out. The solid.
Yeah, what is that?
I haven't seen it before, but it don't look right.
Okay, it doesn't look right. Do you know of anything that tells the heart to beat? Somebody's given an answer. Yeah. Tara, good job. Tara says pacer spikes.
Yeah, I just saw it.
So what's happening is, electrically, this is the same as your P wave, and then you have a ventricular pattern. So a paced rhythm looks like a bundle branch block, but look at the difference between the two. We're going to go up, boom, boom, boom. All right. Hold on. All right, there's our bundle branch block. All right, wide, but it's firing on its own. This one is not firing on its own because there's a pacer spike. And I'll tell you that your newer machines, this pacer spike is tiny and it's hard to see. So you could be easily fooled. That's why you have to examine the patient, put your hands on a patient, feel their chest. I had a paramedic not too long ago who called VTAC, and it was just a pacer. They did not put their hands on the patient. A, B, C, D, E. E is exposed, right?
Right.
All right. Good job, Jason. That was a tough one. Okay, we got two more. Who's up? Oh, there we go. All right, Tara. There you go. So, fork or a spoon. Fork looks relatively normal. Okay, well, let's look through it. Let's take it apart one at a time. One AVL, V5 and V6. They look pretty normal. One AVL, V5 and V6, those are our lateral leads. They look pretty normal. They look normal to me. 5 goes down to the baseline. Okay. Now here's lead 2, 3, and AVF. Do they look normal? This looks, whoops, sorry, I don't know what happened there. This looks a little wide, but it's just 1, so I wouldn't worry about it. So 2, 3, and AVF, would you call them normal? Yep, they all have a PQRST, and the baseline is pretty level, so they don't look bad. Now, let's look at V1 and V2, and V3 and V4. Do they look normal? All right, ST depression in 1, 2, 3, and 4. What did we say a couple of EKGs back that might be? Septal anterior. If septal anterior would be correct if there was elevation, but this is depression. Remember that the posterior segment of the heart doesn't have their own region. So we have to infer deep depression in 1, 2, 3, and 4 as posterior. So let's take a look. Here's my trick. there's one of two things you can do. You can take this and run to the bathroom mirror, right? Or you can grab the piece of paper, hold it up above your head and look at it in the light and turn it upside down and backwards. You flip the EKG upside down, you can see the elevation, right? See that trick? Now, do they look like firemen's hats? Now they look like firemen's hats, right? Yeah, it's a posterior MI. That's it. All right, so that's a hard one, but that's a trick. When you see that deep depression, especially in 1, 2, 3, and 4, you automatically hold it up to the light. Boom, there's your answer. Okay, last one. Who's up? Good job, Tara. Does some elevation in AVR add to that diagnosis? Here, let's go back one. And yeah, you know, so what Gary is saying is we got a block there, one block of elevation, very, very subtle. I'd say that's a really good pickup. And our right-sided lead, if we did a V4 right, might actually show elevation. So yes, that's good, Gary. Good. All right, who's next?
I believe that's me.
All right. All right, this is our last EKG. All right, here we go. Fork or spoon?
Spoon.
All right, where's it spoony?
Pretty much the majority of it.
Okay.
So we have ST depression in leads 1, AVL, V2, V3, a little bit in 6, and then elevations in 2, 3, AVF.
Okay.
And then flip T's in V1, which is a potentially a normal variant,
Yep.
and ST depression AVR.
Good. All right. So mostly elevation in the
Inferior leads.
right anterior. Okay. So the machine says acute MI suspected, left atrial enlargement, ST elevation, consider inferior injury. All right. So inferior MI or acute anterior MI. 2, 3, and AVF is your inferior leads. So there's an MI. And then we've got some depression here. Might be some posterior going on too. So good job.
Would
All
that
right.
be something you'd see with like a right main occlusion?
Yeah, sure could. So now we've diagnosed the STEMI. We've woken up the cardiologist. We called in the CAP team. Now what do we do? Okay, so this is our protocol for Heart 1 or acute coronary syndrome. We have an activation number. We tell them not to activate Heart 1 if there's cardiac arrest and then ROSC with or without ST elevation, because those patients usually need to be cooled. But they do take these patients now to the cath lab. If they're greater than 90 years old, if they have less than 90 blood pressure or then respiratory failure, if they're a stroke patient with an ST elevation, if the patient's a DNR, and transfers from hospitals or clinics when the cardiologist has already been consulted, so that would be a transfer. They call the bend number, that's our large hospital here. And if available, transmit the 12 lead to the destination hospital. We have our printed right on our protocol, our leads, so that we know our regions. And that's it. Questions? Do I have any questions about today's EKG lecture?
Well, we got Gary saying no, thank you very much. Tara, I found it super helpful. Cardiology is my weakest point.
All right. So
Jason,
go back.
you
This
did
is
good
on.
for an EMT there.
This is online, so they can look at this anytime, right?
Yeah, I will be saving this and posting it within the next couple of days in the MD Roundtable. And for those of you who are not P2 students who jumped in tonight, I will look and see what classes you're in tomorrow and go in and give you a chat room credit for this because you all got to participate and did a good job. All right, Jason said thanks for everything. Thank you, Dr. Eschelbach.
Oh, you're right. You're welcome.
All right, good night to everybody. We'll see you soon.
All right. Good night.